Yes.
Perfect. All right, so we'll get started. So welcome everyone to the NCH Community Health Improvement Plan work session number one. My name is Ren Anderson, and I, along with Scarlett Moberly, who is our Grants and Community Benefit Coordinator, will be facilitating this session today. So we're so glad to have everyone in the room. We have lots of wonderful voices and input and ideas in the room. So really excited to see how your ideas and voice shapes community health in the North Country. So today we have a few goals. We want to reconnect with the voices that shaped our community health needs assessment. We also want to help deepen the shared understanding of the three regional priorities and make sure that you are hearing the same things that Scarlett, I, and the North Country Healthcare team heard. Um, we want to identify any themes, but especially gaps that we heard in our storytelling and possible directions for any action steps that we're going to take. We want to set the stage for shaping clear community informed goals. And we want to leave today with some next steps and a path forward for session two, where we'll really dive into the smart planning of a goal, making sure that everything is measurable and time bound, especially. So before we get started, I know we have a lot of different voices in the room today, but we might not all know each other. So we'll kind of popcorn it around. If it's okay with everyone, I will just work off of my grid and who I see. So just give your name, your role or connection to community health, and why this work matters to you. We'll start up in my top left corner, Lori Moran.
Turn on my audio. Sorry about that. I'm Lori Moran. I'm a Weeks Medical Center Outpatient Practices Quality Coordinator. And this work matters because we have currently over 14,000 patients within our practices,
Thank
and we
you.
need to care for them.
Yes, we do. Jessica's here.
Hey, I'm Jessica. I'm the town manager in Lancaster and also the welfare official. So I just hope to bring my own perspective to this conversation. And it's important to me, specifically, based on my work with welfare, but understanding the community as a whole helps me put in perspective the services that we're providing to residents. So thank you for this opportunity.
Wonderful. Thanks, Jessica. Kelly.
Good morning. My name is Kelly Dusso. I am the Executive Director of the COAS Coalition for Young Children and Families. And this work matters to me as our coalition, among many, many partners, are really looking at sort of overall systems integration for our birth through age 8 population and their family systems. And in particular interest to me in the coalition is really the behavioral health work, which I believe is one of your priorities, as we are also embarking on a more community-based, non-clinical behavioral health response to the needs of children and families within our catchment region. So thank you for inviting me.
Thanks, Kelly. Mary.
Good morning. My name is Mary Van Alstyne. I'm a nurse practitioner for North Country Home Health and Hospice. We are the only outpatient outreach group for home health care, long-term care, a little palliative and hospice from Plymouth to Canada. There's two nurse practitioners. I work the South. There's Lynn Beatty up north, and we have a medical director. We're in homes all day long, and things are tough out there. We've got a gap for education in terms of a number of health problems, behavioral health being one, dementia being another. And one of the things I'm hoping to work and start is a grief group for children. I came from upstate New York, and we had a program called Wave Riders, and it was geared towards grieving for children for whatever their losses were. And I finally got a contact of the woman who started that. So I'm looking to help the North Country, as all of you are, and I appreciate working with you. Thank you.
Thanks, Mary. Scarlett, do you want to introduce yourself briefly?
Sure. I'm Scarlett Moberly. I am the Grant and Community Benefit Coordinator at North Country Healthcare, and I'm working with Ren on the CHNA and the CHIP. So thank you all for being here.
Okay. James?
Good morning, James Patry. I'm the Vice President of Marketing and Community Relations for North Country Healthcare. The importance of this can't be overstated now, given what we're facing in terms of changes at the federal level. So that's motivating me, as well as what Lori indicated, our entire patient roles within the North Country. So glad to work with everyone on this. And I wanted to especially give a shout out to Ren and Scarlett, who have worked so hard to get us to this point. So thank you.
Thanks, James. Caitlin?
Caitlin Martin, I'm an RN case manager at Weeks Medical Center in the outpatient clinics. And we're really taking a focus on the social determinants of health and how they play a factor in the overall health of the patient and how we can keep them healthy and out of the hospital.
Thank you. Ashley?
I'm Ashley Claus, a registered nurse and outpatient case manager that works with Caitlin at Weeks Medical Center. Also a diabetes educator here at Weeks Medical Center with Mary Beth Kennison. And like Caitlin said, just really focusing on the social determinants of health and what resources we can really offer to our patients in the outpatient setting.
Wonderful. Nicole?
Sorry, I don't have my regular mouse. Using this pad does not work well for me. Good morning. I am Nicole Jones, and I am the Integrated Community Services Manager at Amanuset Community Health. I'm relatively new to the role, but I've been working in healthcare and human services for a really long time. This work matters to me because a few of the departments I manage here are related to early childhood development, food insecurity with the portable teaching kitchen, medication assistance programs. So it really just all kind of ties in with the departments I manage and getting the resources out to the people in our community who need them.
Thank you, Nicole.
Yeah.
Karen?
I'm Karen Gagnon. I am the North Country Healthcare Inpatient Case Management Manager, registered nurse. Like Caitlin and Ashley said, it's important to us to make sure that we are using all the resources and meeting all the needs and identifying needs so that when we discharge patients from our hospitals, that they can stay at home and not come back.
Thank you, Karen. December?
Oh, yeah. My name is December Rust. I don't know, I'm an unhoused community member here in Littleton. I'm here just to kind of listen, see what, kind of what the studies have found, what the gaps are that need to be filled. I'm currently working with a couple of people to try to fill some of those gaps in Littleton because we've already seen some of the issues, and I'm here to listen and see what I can find out. So thank you.
Perfect. Thanks, December. Chris?
Hi, folks. Chris Van Bergen. I serve as the Director of Workforce Development and Public Health Programs for North Country Health Consortium. And this work matters to me on a couple of levels. First, in my role as the Director of the Northern New Hampshire Area Health Education Center, I'm focused on finding ways to enrich the healthcare workforce for the region. Our footprint is almost the same as NCH's footprint, a little bit bigger. And then as the director of our public health network, we're tasked here at the consortium with creating a community health improvement plan for the public health system. And the healthcare system is an important component of the public health system. So the work that's done by our healthcare partners gets incorporated into our regional public health planning. And then really just on a very personal level, I'm a lifelong North Country resident. And so NCH is my medical home, and I'm very interested in helping in any way I can to make that a nice, strong system for me and my family.
Thank you. Well, wonderful. So, I mean, we all have different backgrounds, but it sounds like everyone cares deeply about their community and community health in general, and how do we keep our patients, our friends, our neighbors healthy. So really appreciate everyone being here today. As we go through, just a couple of key points. So remembering as we have these conversations that they might bring up sensitive issues. So if you need to take a pause, take a bio break, do whatever you need to do, that's absolutely fine. We're here about improving real lives in our region, and that can be very, very emotional work. Our community health needs assessment isn't just a requirement, it's a way to listen to our communities. And in general, this work group exists because we believe in action, not just the analysis part of our CHNA or community health needs assessment. This group today, and all the work that we do is collaborative. You're not here to rubber stamp anything. We want your wisdom, your lived experience, your voice. This group is diverse for a reason. We need a range of perspectives to do this right and make sure that we're representing our community well. We have 3 priorities, but we recognize that priorities can't always be set in stone, especially with a changing political environment. They reflect what we heard, but we also have a chance to really deepen, sharpen, and ground these in real goals, and that's what we'll be asking of you as we move forward. Themes overlap. We've already heard that in our work. You might not be directly in healthcare, but you care deeply for your community, and that's okay. We recognize that real life doesn't fit into tidy boxes. We will be reviewing some of our data today, and I think that it's just important to remind everyone that there's stories behind that data. So we heard from real people about transportation, about trust, housing, food, and hope. And we want to use both quantitative and qualitative voices to help shape this plan. So at any point, if you have stories to tell, or you think that there is a community member in our community that's not represented, and Scarlett or I should reach out to hear that story, please let us know, and we would be happy to do so. The work that you do in this group is shaping future goals. They'll be proposed to North Country healthcare leaders for formal adoption, including both our cabinet and our governing board. And so what you help build here impacts how we designate funding, what programs we invest in, partnerships we pursue, and overall policy. Work between the sessions. So we're trying to be very mindful of your time. Everyone has a lot of meetings. So you'll receive a draft of goals based on what we hear today. After you receive that draft, it's a chance for you to refine the language, share resources, or flag gaps. Maybe we didn't hear something. Maybe there's something that we should drill down a little bit further to. So we're really looking for that shared ownership through this process. And I'm just so appreciative to everyone who's volunteering their time here today. We recognize that this work is messy and complex, and healthcare in general is, and communities are, but it matters so deeply to us. So just thank you for showing up and committing to community health. So we've used the abbreviation a lot. I've tried not to slip into jargon when it comes to acronyms, but what is a CHIP? A CHIP is a Community Health Improvement Plan, and it is a long-term collaborative effort to address health issues in a specific community. And we looked at our specific community. If you were able to join us for the Community Health Needs Assessment Survey present outs, you saw that it was all of Coos County as well as a good chunk of Grafton County. And we looked to identify the community's needs as well as its strengths. And our hope is that it outlines a roadmap for addressing identified health priorities, including objectives and strategies to improve the community's health. There are 4 key components of a good CHIP, including priorities or specific health issues that will help the CHIP focus on, goals, including broad statements about what the CHIP aims to achieve, objectives, specific, measurable, achievable, relevant, and time-bound SMART targets for achieving the goals, and then strategies or actionable steps to reach those objectives. And then it's all tied back to evaluation. How are we doing? What are the mechanisms that we put in place to track progress and measure the impact of the CHIP as a full and what our success is? A community health needs assessment is done every 3 years. So we are really looking at time-bound action plans to try to move the needle in the next 3 years. So from 2020, September 2025 through till through 2028 when we do our next one. We want to make sure that they have a long-term focus and anything that we plan is sustainable. So not looking for short-term fixes, but really those more comprehensive long-term plans that will create lasting improvements in community health. These vary in each community. They're really driven by the communities themselves, but they often include areas like behavioral health, chronic illness or disease management, maternal and child health, and public health and emergency preparedness. So that gives us a kind of a starting point so that we all understand what we're doing here today and what our outcomes are. Scarlett is going to do a quick review of our community health needs assessment findings, just so we can refresh and move the conversation forward. Does anyone have any questions before we do that? No? Great. All right, Scarlett, I am happy to drive if that works for you.
That's great. Thank you, Ren. So as Ren said, this is going to be a quick overview. I'm just going to breeze through some of the high-level data from the CHNA, just so it's all top of mind and we can remember what we looked at close to a month ago. So to begin, just as a reminder, primarily the CHNA was focused on the North Country Public Health region. There is not always data available at that region level. So where there was not, we did pull in county level data of Coos and Grafton counties. We just like to make this point clear because as we are all aware, some of the demographics from Southern Grafton tend to influence the data when you're looking at Grafton County data as a whole. So we do try to focus on the North Country region so it's most relevant to our needs. Next slide. As a reminder, in the North Country, we're looking at almost 52,000 residents living here. And one of the main points from this health needs assessment and in general is that over a quarter of that population is 65 plus, which is higher than the New Hampshire average at 20%. And again, our median age in this region is 10 years older than the New Hampshire average at 53 versus 43. So that's going to influence both our results and the population that's utilizing our healthcare system the most. Another point that is relevant to a lot of the data in the health needs assessment is that the median income in the North Country region is significantly lower than the New Hampshire average, about $30,000 less at 52,000. We can move on. So first, we're going to look at some of the data from the community survey reflecting that demographic data. The respondents to the survey noted that older adults, 65 plus, and low income groups were the top two priority populations that we should be looking at. Some of the qualitative responses we heard about needs in the community were the lack of public transportation, the need for expanding telehealth services, the lack of providers, and the need for increased access to medical and dental care. Yep. As a reminder, the survey asked respondents to look at health needs in our community split into 3 categories: health factors, community factors, and behavioral factors. This slide shows the top health factors that were rated by the respondents. You see the top one, 73% of respondents weighted mental health as extremely important to address, followed by cancer and some other chronic diseases. Okay, next slide. Community factors, the top two, both at 70%, were the affordability of healthcare and affordable housing as the primary concerns that we should be addressing from the results of this survey. We can move on. And then for behavioral factors, the top two were adult and youth drug and substance use. But you can see that this entire category was pretty dominated by the use of legal and illegal substances. So that's going to be a big concern as we see. And next slide. So we took those results of the three categories and combined them to find the ranking based on weighted average of all the priorities that need to be addressed based on the survey results. Here you can see the 2025 survey compared with our 2022 survey, and then all the way on the right compared with some national results. A lot of consistencies throughout both our surveys and the national results. You see mental health at the top for all three. And within our two surveys, you can see there has not been much change between the top 5 or 10 issues, just some differences in rank order as we've moved through the past 3 years. And what I think is interesting to see is that all of these on the list really fall into the categories of behavioral health, chronic disease, access to healthcare, and some social determinants of health issues. So just to remind you, we took that survey data and then looked at it in comparison to available public health data to see if the trends between both were matching. As we saw, they were. Mental health was our top concern in addition to substance use issues in the survey, and compared to the publicly available data, that lines up. You can see that the North Country has worse rates of suicide mortality, suicide or self-harm ED visits, opioid overdose deaths than New Hampshire. Interesting lower rates of opioid overdose ED visits, which could potentially allude to a lack of early intervention, lack of access to emergency rooms, perhaps a lack of transportation to those. We can move to the next slide. Thinking about chronic diseases, again, the North Country region fares worse than the state average in heart disease, cancer, stroke, and heart attack. Also in diabetes prevalence, interestingly lower than the state average in pre-diabetes prevalence, again, suggesting a lack of early screening or interventions or preventative health care. Thinking about access and affordability, it's going to be no surprise to any of us here that our region is entirely encompassed in a health professional shortage areas, both for primary care and mental health providers. And indeed, mental health providers, our entire region is designated as a high needs area. Again, thinking about those issues of access and income and how they're related, we saw that our median income is much lower than the state average. We also have a slightly higher uninsured population and a significantly higher rate of no vehicles for the household, which can lead to transportation and access issues. Thinking about social determinants of health, in our survey, we asked respondents to rank which social determinants were most negatively impacting the health of the community. The top one was housing instability or inadequate housing, followed by poverty and lack of transportation, tied with limited access to healthcare services. So again, seeing those responses reflected in the data, we have over almost a quarter of families in the North Country living below 2 times the federal poverty level, lower rates of education attainment, almost double the New Hampshire rate of households who receive food stamps or SNAP in the North Country, and higher rates of homes built before 1970. I thought it was an interesting comment in one of our sessions. Someone asked, well, what's so wrong with houses built before 1970? Me and everyone I know lives in a house built before 1970. And I think the point to think about when looking at that statistic is that if you have the means to modernize and maintain the upkeep of a house built before 1970, then there may be nothing wrong with a house built before 1970. But if you don't, then you are potentially looking at issues of unsafe electrical systems, lead in paint and pipes, um, lower energy efficiency, which leads to higher utility bills and just higher rates of upkeep in general. So if you have a lower income, all of those are going to be harder to keep up with. And then about the same rate of substandard housing in the North Country as in New Hampshire. Substandard housing just reflects housing that has issues of infestations or lack of regular utilities. Perhaps there's no running water or access to electricity, or issues such as that. Maybe there's not regular kitchen appliances available in the home.
And I think it's just interesting to frame and remember that they're saying that almost 25%, so almost 1 in 4, we're seeing that as an issue.
Yes. So we then took all that data and determined what some potential priorities could be based on that data. We saw behavioral health and mental health come out as really top concerns. So improved behavioral health outcomes was noted as a priority. Access issues across the board were rated highly. So increasing access to local healthcare services became a priority for the CHNA, and then reducing barriers to care, which includes not only the affordability of healthcare, but also all those social determinants of health, addressing those so that our population can focus more on their healthcare needs. We took all of that data, and as you all participated in, we did a series of community listening sessions. We were all at different sessions, so we just wanted to cover some of the themes that we heard throughout those sessions, so we can all be on the same page about what our kind of ideas and priorities are coming out of those listening sessions. Consistently, we heard that the availability, knowledge of, and access to existing resources is lacking. And those that do exist often carry a stigma or sense that they're not for me, or I'm not that bad off. Oops.
You might get taken ready.
And the resources that do exist, it was said it's difficult to maintain up-to-date lists of those to provide to clients and patients because we'll have good ideas pop up and then fade away as funding cycles move through or passionate staff moves on from different organizations. There's also no good closed loop referral system in the North Country, and that hinders follow-up and follow-through for those trying to access those services. And we heard about the difficulty of navigating healthcare and social services systems can thwart even those that are really ready to navigate those, that are healthy and well educated and well resourced. So we know that the people we are seeing in all of our organizations are perhaps not operating at 100% by the time we see them. So trying to think of ways that we can help them navigate those systems that are difficult to access in general. And understanding that there probably is going to be a why should I try mindset with a lot of the people we are working with because the systems are so difficult to navigate and they've probably faced multiple failures before. Thinking about some social determinants of health, we heard transportation as a recurrent theme throughout all of our conversations. Interestingly, transportation did not rank particularly high on any of the priority lists. We did ask Kylie, our consultant, who you remember gave the presentation, if that's something she sees often in these conversations. She deals primarily with rural health networks doing their CHNAs. And I thought it was interesting. She said that happens almost every time she does this, that transportation does not rank high. in the data, but then in the conversations, it's one of the primary topics that comes up over and over again. So just thinking about how the data can be skewed in its own ways, and then we also have to think about the challenges that we are seeing in our day-to-day work. Thinking about transportation, we heard that, of course, there's limited public transportation available in the North Country, and that does exist. There's a real lack of knowledge on what the schedules are, where it stops, and who can access it, whether it's available to everyone or if it's for only seniors or low-income groups or any access issues there. We also discussed a lot about the varying definitions of transportation insecure and how that compares to someone who may be functionally homebound. Transportation insecure is often defined as not having access to a vehicle, but the same issues apply if your vehicle is unsafe to drive in winter, or if you have an inability to drive at night or long distances where you are too ill to drive. Or perhaps you took an ambulance to the emergency room, but you don't have a ride home and you don't have any friends or connections in the area to give you a ride home. What then do we do? Thinking about food insecurity in our region, that is worsened by perception barriers and stigma is a lot of what we heard. We had conversations around how, though it's great, we have a really robust farmers market system and that we have several local food co-ops and kind of farm to customer stores to perhaps people who are receiving food assistance benefits. Those retail outlets are deemed inaccessible and there's a perception that they are cost prohibitive even when you have systems available like being able to use your SNAP benefits at the farmers market by getting tokens. Then we heard, well, there's a stigma of standing in the food stamps tent and having your friends and neighbors seeing you get your tokens, or perhaps they're behind you in line at any of the tents and see you paying with tokens that can deter some people from utilizing that system. And we heard the same thing about using the EBT card, which was meant to be inconspicuous at grocery stores, but due to kind of restrictions, it can present challenges at checkout, which can deter some people or just increase the level of stigma in using it. As far as access to healthcare and behavioral health issues, in general, we just heard more and better behavioral health resources are needed across the region. We discussed that the link between mental health and substance use are often not addressed or overlooked, or perhaps they're treated separately when the connection to the two should be addressed together. We heard about the comprehensive need for behavioral health and SUD programs across our region, and those that do exist are kind of isolated in various pockets throughout our region, and they don't reach enough people. And those that do exist, we heard about a lack of awareness on what does exist, how to access it, and particularly mental health resources. We heard about a confusion or a misunderstanding about whether it's available at any time or if they're only available in crisis or emergency situations. We know that access to healthcare is limited by locations and hours. We saw that in the data, and then we saw that in our community conversations as well. We heard about the difficulty in maintaining regular healthcare, as it's often a choice between paying for childcare or missing work. And then even if you can get there, how do you get back? And then we heard about the cost of healthcare as a barrier being exacerbated by the difficulties in navigating complicated insurance coverage policies, kind of a confusion or a misunderstanding about what is a deductible, how does it apply to various medical procedures or bills, what is my copay, when does that apply, and whether anyone is eligible for Medicaid or Medicare. So now that we have done all that, we now are in these conversations, our CHIP conversations, to determine where we're headed. So I'll hand it back over to Ren.
So as we think about improving behavioral health outcomes, increased access to local healthcare services, and reducing barriers to care, those are going to be our main focuses again for the next 3 years. And we have identified this group as being voices of the community that can help us form that action plan. So we're going to go through a series of questions and really looking for voices to be heard in this. You've heard what our community told us, but we want to start drilling down on that and think about what are some actionable goals that we can take from just listening to creating improvements, actions, and strategies to create healthier communities. So we'll go through, I'll be taking notes as I'm asking questions, so feel free just to popcorn your answers. Also, Scarlett, I'll ask that you monitor the chat for us.
Sure.
So if you prefer not to speak up in a crowd, we absolutely acknowledge that, and we want your voice still to be heard. So please feel free to put things in the chat and we'll grab them that way as well. Any questions?
So feel free to email us later if you don't want to bring it up now or if something comes to mind at a later point.
Yeah. So any questions before we start diving into the questions? When you think about a healthier North Country, what comes to mind? What would success actually look like in our communities?
For me, success would look like not being at the bottom of the heap in terms of sickest, poorest counties in the state. I speak about COAS in that regard.
What else? What does that healthier North Country look like?
I say increased patient compliance.
And Caitlin, can you talk about that more? What does compliance mean in your mind? Is this an educational opportunity? Is this a communication opportunity?
Yeah, I mean, I'm just not sure that a lot of patients know what resources are necessarily available to them or even want to ask. A lot of patients, they're really, really sick out there, but we don't hear about them until they are admitted to the hospital or whatnot. So how do we keep them healthy at home until we get to that crisis point of being admitted?
If I can add on that, I think that for me, what healthy or would look like and feeds into all of these issues is less isolation. What I'm seeing is people being really isolated. And that I think we also have to consider transportation as a vehicle, but the communication issue is also internet. And we have a big lack of that as well. So the isolation is what I'm seeing is kind of killing people, frankly.
And I would do a yes and there for me. I would say a healthier North Country looks like a population that enjoys better health literacy. We definitely have established health curricula that are carried out through school years, pre-K through 12 to varying degrees, but it's largely focused on the very basics of like brush your teeth, shower regularly, eat good fruits and vegetables. There's some reproductive education that happens there. And then folks are kind of launched out into the world, and there's not really a time when they receive really solid information about the prevention of chronic disease. For example, James, you spoke to, like the disease burden of the North Country. Our folks, they don't necessarily have good education ongoing about how to prevent the development of chronic diseases, and our careers, the occupational exposures that are common in the North Country are harder. In some cases, we have more physical labor, we have more exposure to chemicals and the like. And so I think if we could work upstream, improve health literacy, improve uptake of preventative care, we might see that be an improvement in the health status of the region. Um, Compliance, it's just funny to hear you say that, Caitlin. Patient compliance. Before this gig, I worked in quality, healthcare quality for 17 years, and um, compliance became one of the words I liked least because it implies that they have to do what someone else says, and it strips them of their autonomy and empowerment. And in the healthcare system, and I think this is exactly why I listed into these conversations. Within the healthcare system, we operate in a very controlled environment, right? Like a very sterile environment by design. The lights are bright, the walls are white, everything's clean, lots of hand sanitizer, all the things. And then people go out into community and live their lives. And the dog throws up in their shoe, and their car breaks down, and they can't get to PT, or they can't afford their medications. And
Right.
so, if we can work upstream to prevent the development of those conditions in the first place, then it doesn't matter how great our care plan is in the hospital. We're able to have a care plan in community that works because it's less intensive.
I think for any of us that go into homes, having been a hospitalist and an ER provider, the dynamic is totally different. I don't have a white coat and a stethoscope on. I tend to, you are literally, I tend to try to sit below people and have conversations in their setting. And it's a lot. I'm going to tell you that it's a lot to be in their environment and try to figure out how are we going to do this? Right. And it was eye-opening to say the least. And again, the isolation is a big piece of this, particularly for the elderly, single moms, people that just don't have community around them. There's a real crisis of that.
I feel like the North Country, we're also, very stoic, very, don't want to ask for help. I can do it myself. And figuring a way how it's okay to ask for help. How can we, let them know, you don't need to be on death's door before you, come in, ask for help before, how to, help them ask for help sooner rather than later.
Well, if I could speak to like patient burnout, and yeah, I can't tell if I'm actually if I'm on or not.
Yeah, we can hear you.
Okay. I'm sorry. Like I haven't used Zoom on my phone and okay, sorry. Yeah, so what I've experienced on this end is complete patient burnout, and so I appreciate that the conversation was brought up around the mention of the word compliance, because even when we comply, we still get dropped through the cracks. So what happens on our end, and I'm not an elderly person, and I'm not, I mean, I have children, but I'm not a child, so I'm an adult male, and therefore even in just that last comment, I fall in the cracks because I don't qualify as part of that vulnerable population. So there's huge gaps in the way that patients are perceived, that in the mention of the whole closed loop idea is that there is no one ultimately other than the patient themselves looking out for the patient, because there's so many specialists that we get referred to, and then the transportation company double and triple books, and then because they're getting paid by insurance, they don't care. And so, but then we're late to appointments, and then the doctors don't, they care that we're late or that we don't show up, but they don't care that it was a transportation company's fault. So then we receive a letter in the mail from the specialist at wherever, and saying, well, you missed this appointment, you missed one more, and you don't get to come back for another year or whatever. So there is a complete disconnect. We are treated completely like number, and I'm not saying by everybody, so this is not a blanket statement on everyone in the healthcare industry in the North Country. But what I've experienced personally from the burnout is that there's so many different whether it's a question of being understaffed, whether it's a question of I don't know what the problem is on the other end, but I know that I was doing everything right, and consistently everyone else was dropping the ball. Everyone getting paid to do a job to help me because that's their job. If you're in healthcare, your sole job is to help the patient. So not to be dismissive, not to deflect or anything like that. So that to me, when I think of a healthy North Country, I think of patients who aren't dismissed, clients who aren't dismissed. I think of where we don't have 3-month wait lists to see a mental health professional in Littleton when we have 3 different agencies. That does not, there's no reason that should be the case. So when we talk about compliance, when we talk about things like that, oh my God, on our end, it is terrible out here. So we're not sitting behind desks. We're not sitting behind these things. We're out here feeling lost, feeling left, feeling like completely disregarded. And that's, and that's not just my story, but that absolutely is my story. So I don't have an answer, obviously, but there has to absolutely be solutions out there. And because there's so many people that are in the system working on it, how is it possible that that there's not solutions? So I'll stop. I've gone long enough, but I appreciate this opportunity to express this because people are dying. That comment was made. People are dying. People are depressed and scared, and they should not feel like that in this world. In a world of 8 billion people, people should not feel like that. So thank you so much for allowing me to share, and I'll stop now. Thank you.
Thanks.
Thank you for that
Thank you.
perspective.
Thank you.
We're
And
also seeing in the chat that perhaps there's also a lack of trust in the healthcare system, particularly since COVID.
Agreed.
I want to bring up something that I've heard a couple of different times, and that's around health literacy and educating our patients and our communities. I think all of our organizations that are on this call have hosted some sort of healthy learning, healthy eating, maybe I know Ammonoosuc Community Health Services does a pretty vibrant kitchen program for healthy eating. But how do we get people to show up for it? Because I think that's a trend that we see often. We try to host a community event and then nobody comes. So then the literacy and education doesn't happen. How can we be where the people who need it most are? Has anyone given that any thought?
Yeah, I think you just said it, Ren. Honestly, be where they are. Don't expect them to come to us. It needs
Right.
to be a push methodology, not a pull methodology. Um, when people are out there living their best lives, they don't want to think about being sick. And when they are sick, it consumes their bandwidth. And so I think we try in these very active ways to pull people towards us, pull them towards the resources. Thank you, December, for your input. I was listening to you and thinking when I first started my career working in healthcare quality, one of the first things I read was the quality chasm, which was a report by the Institute of Medicine published in 2001 that talked about how the gap between what was possible in the US healthcare system and where we currently were was a chasm, not a gap. And one of the things that it spoke to was the need to address convenience, and that the system is really modeled for the convenience of the people working within it, not the people they're working for. And I think from a public health perspective now, 20 years further, I definitely see that where we have incredible resources at our disposal within the healthcare system. And the healthcare system is generally designed to deliver care in its space. And I think there's an opportunity to share responsibility across the public health system to to move some of that information to where people are. We've seen great success in other parts of the country with things like blood pressure screenings and education about hypertension in barber shops. When barbers are trained to do a blood pressure screening before they cut your hair and then have a conversation with you about how to manage your blood pressure while they're cutting your hair, because it's happening within your community, within the culturally sensitive space. And I really think for us, that's a component we need to think about in the North Country, because first of all, we're sparsely populated. The footprint you're talking about for this chip is 35% of the state's geographic area, and it's home to only 3.5% of the state's population.
Right.
So just pulling people together is super challenging.
Right.
And we're well past the time of like feed them a spaghetti dinner and offer some 4-Hers to take care of their kids and they'll come sit through a talk. That's not how people receive information anymore. NCH has been really successful in the last couple of years, actually, with some of the public service campaigns that have been out there, whether it's your vaccination campaign, which I think was really fantastic on the heels of COVID when people just didn't want to hear about it. Thinking about some of the campaigns you've done around breast cancer awareness and cancer screenings, pushing it out to where people are. We should be present in laundromats and grocery stores and community festivals. And frankly, I'm not sure that's where healthcare providers who are exceptional at providing acute and primary care would or could be hanging out. I think it's about partnerships and collaboration. We have librarians across the North Country who are begging to be more engaged in the way people stay healthy and get their resources. And we could be tagging them to help us with some of these campaigns too.
Thank you.
Absolutely. Is there, the question I'm sure will come up at some point is what are the resources that we have to work with? I mean, is there resources for a mobile unit that would be able to go into communities? I mean, granted, we have people that are literally out in the middle of nowhere, and that's kind of hopefully an outlier, but I see little, clusters of communities that if someone were able to reach out to them with, some sort of van or whatever, what are the resources going to be that we have, Ren? Are we looking at grant money? Are we looking at, I mean, that's the problem.
Yeah, I mean, I think that's where
I-
we're going with this conversation as well, is where do we need to put some of those efforts? Where do Scarlett and I need to concentrate our fundraising to put back into these resources? And where do we need to allocate our time within those third spaces that Chris just referenced? So we don't have an answer yet, but I'm hoping that we'll at least create some action steps to getting towards those answers.
Okay.
Yeah, and I can offer to you, Mary, there are a couple of mobile integrated health programs that have operated in the North Country recently, and I literally signed a sales agreement yesterday on a van that our organization has had for 3 years and been unable to get into community to deliver care. And it is partly a funding issue, but more importantly, it's a workforce issue. Like we had the van, we had the assets. It was a program that was stood up in partnership with 4 North Country hospitals. And by the time the physical asset was ready to launch, the staffing shortages across the healthcare system were so significant that we couldn't put clinicians on the bus. And so we had the model ready to rock, and then we didn't have the physical bodies available. So it's a complex challenge.
Right.
There's some really good work happening in terms of community paramedicine. And there are models around the state we could look at that I think would fly better than the challenges we had with the mobile clinic program that we've been trying to stand up. And so what we've done is actually repurpose the funding on that program, kind of along the lines of what I was just talking about, to use community health worker energy to go out to where people are, address those health literacy issues. And in fact, one of the things I'd really love to collaborate with NCH on is we'd like to hold on patienting classes. When physicians are in medical school, they take a course called on doctoring, and that teaches them how to work at the bedside, the soft skills of bedside manner, to make an appointment successful and connect with their patients. And we would love to be doing some on patienting classes around the North Country that help people understand how to communicate well with their providers, what kinds of information is important, how to prepare for their appointments so that they walk in ready to have those conversations. And then if they should be monitoring vital signs at home, things like that, making sure they really have those skills to do that in their home setting. but we have to build a curriculum for on-patienting. And I would love to work with some of your physicians and nurse practitioners to build that out.
Thanks, Chris. So within the 3 priority areas, is there something, I'm hearing some of these questions already answered, but what feels most actionable or urgent within improving behavioral health outcomes, increasing access to local healthcare services, or reducing barriers to care? One of the things I think December brought up was wait lists and just how long that is. And I know I saw Tanya joined us, and she's our HR director for North Country Healthcare. So I know workforce is a big focus for Tanya. And I don't know if you want to speak to it at all, or if there's anyone else who wants to speak about recruitment. But I think that's where we're seeing a lot of access issues around healthcare, and in the behavioral health realm as well.
Yeah, so we have been very lucky having hired a new recruiter for the area. However, it hasn't come with its own set of challenges. You know, people want to be paid at the top of the market and get all of the bells and whistles, which really aren't being offered by a lot of facilities any longer. But it's still a challenge, you know, when we're up against other locations paying significantly higher market pay. And then additionally, you know, there are just certain positions that it's, you know, it's like a needle in a haystack trying to find these folks. And they know it. So it puts us into a position where we have to make really tough decisions on whether or not we're going to be able to offer those particular services and such. But we're trying to get creative in ways that we can get folks to want to live in the North Country. And that's the other part, is that living in the North Country isn't really attractive to a young single male or female who doesn't have an opportunity to go and meet anybody really. So we're stuck with that challenge as well. So
Maybe that's something to think about, because I got recruited up here after I was 50 and at least 55, and it was the best decision I ever made, right? So, you know, I was married, I was an empty nester. It was like, let's go for it. And it changed my world, to be fair. So maybe that's something to think about. We do have an older population in New Hampshire. So that's not, because there's no life up here for young people. That's what they're going to tell you.
exactly. Yeah, no, you're right.
There was a lovely CEO that I worked with in my time at the chamber. He was a CEO of Hitchner, and he said, the only thing that I will be investing in are dating programs and apps for my young staff to keep the doors full. But the older population, no life.
We also hear, you know, they're interconnected. The problems are interconnected. One of the things we hear in our workforce development space through the AHEC is that folks are young professionals who are maybe single or recently married are looking at things like obstetrics care and pediatrics and schools and things for their kids to do. And so, you know, the flywheel, it's spinning on itself when we see the retraction of OB services and the lack of pediatric specialties in the North Country, and people think about how far they have to drive for that sort of thing. It is a turnoff for younger professionals. I also think, you know, there's this opportunity, Mary, that's an excellent point about how you came to the North Country. With a grain population, right? COAS vies regularly with Carroll County as one of the oldest counties in the state, and typically we win. And we're graying not only because our youth are leaving, but also because the Coast County region is seen as a nice retirement spot for folks. It's got a lower cost of living, and there's nice open spaces and recreation opportunities. But they come with their own kind of health challenges as well, which is why they're one of your area populations of interest. So the idea of recruiting folks who are approaching the end of their careers and looking maybe for a more rural experience, something that's less busy, but maybe more interesting, because generalists in the North Country have to practice a lot of stuff. Like they see everything, right? So it might be a different recruitment strategy to think about, just in terms of who we're trying to bring in. Yes, fresh grads are less expensive to hire, but they also come with a whole bunch more debt that they're trying to cover. And that, ties into benefits packages and the like as well, where some of our more seasoned professionals bring a level of wisdom and experience that could be really helpful when they're trying to be a generalist to a patient population of
Right. And
gluttony.
somebody like me who has time and resources to be able to volunteer and to do, I mean,
Right.
I'm completely committed after being here for just under 10 years, to helping whatever I can do for my community. So just a thought.
Thank you. So we've heard some conversation today. Chris, you talked about a partnership for the inpatienting education, but what other local programs, people, or partnerships could North Country Healthcare use to help move that needle? Are there models of work that we're already seeing that we should be supportive of?
Ren, I was just going to jump in. So I think, when thinking about the, particularly access and sort of the behavioral health space, and, I certainly come from a slightly alternative lens from the majority of the group here. I come from public education for the most of my career, in the early childhood space. But what we've recognized is that, those sort of top tier three clinicians are, as everyone just mentioned, getting fewer and far between, right? Having access to those credentialed professionals is difficult everywhere in our nation, but certainly in rural New Hampshire. And I think it's really looking at that prevention model, and moving in a way that, we used to sort of look at tier three clinicians as, the means in which to service whatever it is we're talking about in my example, sort of behavioral health, and really pushing that down. So can we look through that community health lens, the community health worker model when we are supporting behavioral health in rural communities? I know community health worker models and the funding right now is like many other things on the chopping block, unfortunately, but I do think that's where we can possibly look to expand our bandwidth of services. It may not be licensed clinicians out in the field, but a licensed clinician that oversees perhaps, 5 community health workers with an actual model that they are implementing. And we have seen this. We have seen this in other community health worker models. Right now, in the early childhood space, we are doing developmental screenings, both, 0 to 8, but also maternal health screenings in community settings, such as our libraries. And these are being administered through community health workers. And then obviously, if there are needs, it rides, sort of funnels, to the programs and services that these children and families need. But I've always been, I'm an occupational therapist first and foremost, so I've always lived in the tier three space. But I have changed my own practice of pushing down and like, how can an OT support an entire classroom instead of 4 kids? And I think we really have to just start systematically looking at that model, particularly, in one of the, behavioral health, but also access, because I think we can really look at, community level responses through more of a prevention based model before they, need the actual tier three clinician.
Thank you. The community health workers has been a common theme that we've heard through our listening sessions as a wonderful resource. What other programs, people, or partnerships might help move this needle?
I think we need to identify people that have really passionate, driving force to want it to do this. This has to be people's life work and not their job. And I certainly feel that way about end of life and having people have good deaths. I had a little epiphany listening to you all about this program that I would like to develop about a loss and grief for young people, because there's none of that. That it occurred to me that it doesn't have to be a death, that loss is loss. It can be an alcoholic parent. It can be one that's in and out of psychiatric facilities. So I think it made me just kind of go boom and think, this program could be more about loss, and younger people that start to feel despair, of course, get more isolated, might be more apt to drink and do drugs, etc. So that just gave me a lot to think about, and I appreciate that.
So as we think about our actionable goals, we've talked a lot about what that ideal community looks like, how we bring health to the community. But can we build in any small wins that we could aim for within the next 6 to 12 months that might then, as someone used the flywheel, right? Flywheel into more accomplishments and a bigger goal. There's small wins we could aim for within the next 6 to 12 months. I know we have a few practice managers on the call, or people who are working, as clinicians. What would you like to see us aiming for with our patients?
I'm going to speak up finally. I think I am very interested in the piece about sort of the education of patients. I think that's, of course, James may disagree, but I think that's something we could stand up rather quickly. One of the other things that I'd like to see for education of patients is an understanding of how healthcare is now. We have come out of the era of the long time. I have my doctor. I've had him since I was 20. We're no longer like the rest of the industries in this country. People aren't staying with jobs forever. And patients are very disappointed when they've entered into what is a rural health clinic model. A clinic model does not, we have PCPs assigned, but it doesn't ensure that you will always see that PCP for every single visit. And so as part of that health education, I'd like to see just sort of something around that as well, in terms of patient expectations. That's just something that we hear we hear a lot of complaints about that. And it's unfortunate. It ties into the issues that all of healthcare is having, attracting and retaining providers, particularly primary care. I'm not trying to be, tough. This is how it is. That is not what it is at all. But I think we need to let people know that that's kind of what it's becoming. And I do agree that health literacy is very, very important, above and beyond what I just brought up, but very, very important. I think that's something, again, James, don't hate me, but I think that's something we could stand up very quickly to at least get a start on something in terms of population health.
Thank you, Lori.
I mean, I think, listening to December talk, it kind of brought, patients, we think as healthcare providers that patients may understand the process, or, oh, this is why something may take so long, but maybe we aren't doing a good job as healthcare providers talking with patients and explaining things to them. It's kind of become a task instead of looking at the overall picture of the patient's health. At least that's what I see on our end. And really understanding the patient from their perspective, not what we want them to do. But when I talk about compliance, what do they want from their healthcare? How do we help with their compliance to keep them healthy, meeting them where they are? Not telling them what they need to do. But I don't think we're doing a good job explaining stuff to patients, communicating with them.
Yeah. And Mary, I think that probably falls really nicely within your work and goals of care. And can we bring that goals of care conversation to primary care? And what are
Right.
your goals? My goal at 35 is no longer the same goal that I had at 25, and it won't be the
Right.
same as the goal I have at 55. So how can
Right.
we start embedding those goals of care and what you want your outcomes to be in conversations?
I'm going to tell you, having been doing this professionally for 35 years and around medicine almost for 65, my whole life, coming from a very large medical family, your nurses are the people that we need to tap into. That's the fastest way to get to holistic care, because at this point, when I think about physicians, and it's not to blame them, they go to school and they're trained to treat diseases now. Nurses treat people. I don't separate them physically, emotionally, and spiritually. And I also have to meet them where they're at to say, what are your goals of care? And again, for anybody who lives in an office world, sterile world, hospital setting, if you ever go out into patients' homes, it will change your life to see what it is that they are living with and dealing with. It sometimes is appalling. I will tell you. I mean, there's things that I can't unsee. And, you can see it. Somebody might come into the office and seem a little unkempt and disheveled. But then when you meet them in their home, you go, oh my goodness, this is really tough situation. So those are the super vulnerable, the ones that I really care about. And I very much would like to get my program that I want to do up and running in the next 6 months. So I'm hoping that we can all communicate offline and that tap into each other's resources. And I would appreciate that. And again, the epiphany I had, which is grief and loss can be not necessarily a death, but just the loss of opportunity, the loss of life. There's all of that. So I'm on it.
Thanks, Mary.
I think another thing, and I don't know if this would be a small win, but if we could figure out a way to develop, I know it's difficult to maintain what do we have for resources, but as I'm going around to all of our affiliates, and I've also done some work with home health and hospice, we certainly should all have access to the same resources, but we're not all aware of all of the resources. Can we create something where we can point patients, where we can point nurses, where we can point providers to be like, hey, you're the people who keep track of things. What's available to help out in this situation? Because instead of having, 20 people maintaining separate lists, can there be somebody who's maintaining this stuff so that we can all tap into it?
I have part of one of my grants that I'm managing is we call it the Trip Marketplace. We don't have like an official website or app name yet, but we did actually meet with a developer, some real nerdy people, and they talked a bunch of speak that I don't understand a couple of weeks ago. And they are developing our app. It's not going to be Google based, so there won't be any advertising to pay. It's not going to be Apple or cloud based, so there's no downloading and putting it on your phone. It's just going to be one place where we can give the resources for like ride sharing, where we can give resources for food insecurity, for childcare, for child development. So there's going to be a compilation of everything in one spot. And I know there are a couple other programs that already exist. And by a couple, I mean dozens. And everybody says, oh, you can use this. And it's really similar to that idea, but they don't stay up and running. And this one would be locally sourced. It's coming right out of us. So it could be something that could be shared amongst the whole North Country, which is the hope. And we have the money to get it going. So we are doing that.
Awesome.
I think it's really clear we're all going to have to act very locally, like literally within your neighborhood, and expand outward.
Along
Yeah,
the
these
lines of
people have like the ideas all over the country, and that's great, but it's not the North Country.
Correct.
Something that they're doing in New York City might work great there, but it doesn't work here because we're nothing like them. So it needs to be something that we all collaborate on and create.
And
along
so,
the
I mean,
lines
that,
of
and celebrate too, and celebrate the uniqueness. And I always say to people, if you're thinking about moving up here, there's 10 months of winter, 2 months of crappy skiing, and it's not for the faint of heart, but it's a beautiful place to be. And I'm grateful to live above the notch Because frankly, for me, when I go below the notch, it doesn't feel like New Hampshire.
Thanks, Mary. Scarlett?
So,
Yes, I just wanted to say along the lines of being aware of what resources are, we're seeing in the chat as a potential actionable item of all North Country healthcare agencies or service providers getting onto the New Hampshire Care Connections closed loop referral system if they're not already connected.
Yeah, and we've heard a lot of feedback about having a closed loop referral system that also integrates with our electronic medical record system. And how do we make sure that once those resources have been provided for a patient, we know and we can ask and follow up with the patient and see how it's going with them. Because if they've been offered the farmers market 10 or 12 times on their visits, and they're still not using them, we need to dive into why. And is there a reason that that's not acceptable for those people? So thank you, Kelly. Mindful of time, we have about 12 minutes. So this will be kind of our last question, and then we will talk about our next steps and what's coming. So what role could your organization or you and your role play in moving this work forward? If we're tapping into goals, what are we tapping into you for?
I'll offer from the Public Health Network perspective that we are, the public health system is multi-sector in nature. And so we offer connectedness to other sectors. Often our agency serves as a convener, facilitator, conduit to some of these collaborative conversations. And so if there are challenges that I'm just in that last conversation, one of the things that kept ringing in my brain was the idea of being patient-centered. There are limitations on the industry, and some things are just how they need to be in order to deliver care according to regulatory requirements and meeting standards of care and evidence-based practice. However, I think there's an important piece of that is saying, is what we offer and the way we offer it what our patients need and are ready to receive. And so sometimes that means other stuff has to be wrapped around them. Kelly, I very much appreciate your comments about community health workers. CHWs are some of the folks who help individuals with that navigation of services. Similarly, I think our agency can help identify other players across other sectors who can do some gap filling so that the responsibility of solving all the problems doesn't fall within the healthcare system. That is actually exactly why I left traditional healthcare and moved into public health, is that I just really came to this realization that people don't spend much of their time interfacing with the healthcare system compared to how much time they actually have. And I find patients are most willing to be compliant in the doctor's office, but as soon as they leave, life happens. So if there are ways that we can help connect those components of the public health system to address some of those other social drivers, or help promote resources that are available, we're very happy to be a part of that process.
Thank you, Chris.
So can I just ask a question? So is somebody right now that I hear is looking to kind of have, let's call it a database of what is out there? I know it was more than 3 years ago when I was at Littleton, there was a behavioral health volunteer group that dealt on peer mental health issues. Like, I don't know if that still exists. So, I mean, is that something that, Chris, at a public health level is available? Because I don't know. I don't know.
Are you speaking in terms of like staff wellness and support to address second victiming, burnout, that kind of thing?
Just what is available in the North Country, essentially across the board?
So if I could speak really, I know that, and they're not in this meeting today, unless I've missed somebody, but I know that Nikki Leclerc at Coast County Family Health Services has a monthly meeting of resources and has a significant list of local resources, including, obviously they're out of Berlin, but we have shared that with, she has shared that with us and our care management staff here. I would definitely reach out to her. She's more than willing to invite all, put anybody on the mailing list. It's a good starting point. It probably, some of the things are statewide, some of them are regional, some of them are very local. It would be great to not recreate her work, but add on to it.
Are there any social workers in this group? Because that's another resource that I rely heavily on with my patient population. No? Okay.
I'm sorry, Lori, what was the name of the organization or person who put together that mailing list?
It's Nicole Leclerc, and I can send it to you, Ren. She's with Coos County Family Health Services.
Nancy Carney from Granite United Way also facilitates a Working Better Together group that meets monthly in the Littleton area. And I think you'll find that there's not one group or one list of resources across for the whole North Country. It sort of happens around our population centers. So there's also
maybe that's
there's
something
group
we should look
behavioral
to
too.
do. Yeah.
Yeah.
Yeah, and Laura Bushy does the same for Coos County.
Anyone else?
Ren, I know that the COAS Coalition is really actively working on, supporting the closed loop referral system, which, we were part of a pilot in 2022, and we had all of our sort of developmental screening folks on that system, and then the state sort of paused with their vendor of who was going to do the closed. So I think, again, we're talking about this level of connectedness. So there's got to be some level of not replicating all these circles within COAS and Upper Grafton. And if there's one centralized location for all of this information and service provision to be housed, I think that makes good sense. Additionally, we are looking at really supporting the behavioral health space and creating sort of a non-clinical response, community-based response, both tier 3 and putting out fires that have to be dealt with right now, but also through a prevention lens. And what does that actually look like? Very similar to the conversations that we've had today. We don't necessarily have all the solutions outlined yet, but we are collecting our own data in all the early childhood and family systems space, and recognizing that, we need to respond in a way that is both immediate now, but also long-term for systems transformation. So I think the coalition certainly will love to partner on this work because I think we're all talking the same language.
Thank you. All right. So after today, we're going to be compiling and summarizing today's input. There were some great actionable ideas that came out of today. We'll send you a draft set of goals for your review and then ask each of you to share any feedback or ideas. If you have anything come up or someone shares an idea that you think should definitely be on the list, please feel free to email it to either Scarlett or I. And then I'll send out another doodle poll for the session 2. And we just ask that you come prepared to session 2, ready to refine and prioritize these goals. All right. Any final thoughts or questions before we close it out for the day?
We have a question in the chat. Can we start an email group?
Absolutely. I'll stop sharing too. I'm getting motion sick. All right, so that will be an action item for us, is to start an email group. Does anyone oppose to being on it?
No, I asked that and I was wondering, if we additions like social work, if I find somebody that's interested, or even spiritual care, if there's somebody that would like to join this work group.
Of course. The more, the merrier. And we
Okay.
will also we'll distribute this recording within North Country Healthcare as well, so people can hear and see the work that we're doing. So if anybody would like the copy of the recording to go to any of their groups, please let me know and we'll make sure that's available for you. All right. Well, without further ado, thank you so much for all of your work and your openness and